I welcome Dr. Soumik Ghosh on the topic assessment of cardiac risk in patient undergoing non-cardiac surgery. Dr. Soumik Ghosh, MD DM, Associate Professor in Cardiology, IMS BHO.
Very good evening. I'll start off with the topic cardiovascular assessment of patient undergoing non-cardiac surgery. As cardiologists and physicians, we generally frequently get these references from our surgical colleagues and anesthesiologists that how to go about with patients, cardiovascular patients in non-cardiac surgery. So cardiovascular risk and surgery, what does it deal with? Patients who undergo non-cardiac surgery may be at high risk for any cardiac mortality or morbidity, not only during the intraoperative but also during the peroperative, perioperative and recovery period. This risk appears particularly to those patients who are a known case of cardiac and cerebrovascular disease. However, it may also apply to any asymptomatic person who are older than 50 years of age and who have potential to develop atherosclerotic cardiovascular disease. So a thorough examination with non-invasive testing can provide information on 3 cardiac risk factors like LV dysfunction, myocardial ischemia and heart valve abnormalities, all of which are determinants of adverse postoperative outcome. For examination, objective examination includes a vital signs, obviously blood pressure, heart rate, respiratory rate, temperature and oxygen saturation, height, weight, body mass index. Physical examination includes auscultation of heart and lungs, inspection of the pulses and abdominal inspection of and also extremities for edema and vascular integrity. Third is the specific clinical examination of third or fourth heart sounds, rails, JVP distension, ascites, hepatomegaly, dependent edema or any valvular murmur. So the clinical risk factors of a perioperative major cardiovascular event may be a reduced functional status. I'll talk about the METs. A history of ischemic heart disease, either prior MI or angina pectoris, a heart failure symptom, cardiomyopathy, severe valvular disease, arrhythmias, chronic renal failure, a previous cerebrovascular disease, diabetes mellitus, COPD, obesity and also anemia. So further testing, how should we approach? Following a thorough physical examination and evaluation of the risk factors, we should now undergo assessment of the additional preoperative interventions as laid down by the ACC-AHA algorithm. So this is 2024 guidelines. So this algorithm's first step is to consider the urgency of the surgery, whether the surgery is urgent or not. Step 2 focuses on the active cardiac conditions that the patient is facing, whether he is in acute MI, unstable or severe angina, decompensated heart failure state, having severe valvular disease or any arrhythmia. Step 3 now goes into considering the surgical risk and severity, how the surgical insult will affect the heart. So surgical intervention divided into low risk, intermediate risk and high risk groups with estimated 30-day cardiac event rates at less than 1%, 1 to 5% and more than 5%. Step 4 is the assessment of the patient's functional capacity when he is going into surgery, that is the METs. So what is MET? MET is metabolic equivalent. 1 MET equals to the basal metabolic rate. So exercise testing is here very important, an objective assessment of the functional capacity of the patient. Without testing, functional capacity can also be estimated from the daily activities with questionnaires. Then comes the step 5, considering the patient who have an inadequate or indeterminate functional capacity and who need an intermediate risk or a vascular surgery, which is a non-cardiac surgery, which is a high-risk surgery. So here the number of patient level clinical predictors from various risk factors and the risk calculators are taken. The most common is the RCRI calculator. Patients with no clinical predictors proceed to the surgery and those with a high clinical risk factors have to be taken care of. So this is the algorithm what I was talking about, patients with cardiovascular disease factors. If there is no such, then proceed to surgery. If yes, then you just adjudicate whether the surgery is emergency. If it is emergency life-threatening, you proceed for the surgery. If it is no, then you take all the steps and decide how to go for the surgery. So last step is that will further testing impact the decision making? If it is no, then you can we give the green signal for the surgical intervention. But if it is yes, then you have to have the pre-operative biomarker assessment, BNP or NT-proBNP, and also consider troponin as the class 2B indication. If the biomarkers and troponins are normal, proceed for the surgery. If it is abnormal, then a multidisciplinary team approach is necessary, like that of the heart team we have for the cardiovascular surgeries. So if there is any iota of the doubt, then pursue a cardiac examination. Here comes the role of echocardiography, cardiac stress testing, or maybe a CT coronary angiography. And if this is not available, you defer the additional cardiac evaluation and you talk to the surgical team and go for the surgery. So this is another previous stepwise approach that we had in previous guidelines, so I am skipping it. And this is the ESC 2022 guidelines that also had the same type of algorithm. Now the step 2 we had is to assess the severity of the patient on cardiovascular. What are the severity indicators? That is, a patient is having an unstable coronary syndrome, that is either an unstable angina or NST-ACS or ACS, or having a decompensated heart failure, significant arrhythmia continuing, or severe valvular heart disease like severe AS or critical MS. So these are very important to look forward. And then you have to have the step 3 approach, whether the patient is having a high risk surgery, low risk surgery, and a high risk surgery, intermediate risk surgery, and a low risk surgery. So low risk surgery procedures like endoscopic procedures, superficial procedures like breast surgery, cataract surgery, or ambulatory surgery can be a total green signal. But the high risk surgeries like vascular, aortic, and major vascular and peripheral vascular surgeries need to be further deliberated. Now, the functional capacity, we look for the METs. I'll be coming with the METs. This is the METs. One MET is that can you take care of yourself, eat or dress, use the toilet, walk indoors. This is the basal metabolic rate. And up to 4 METs is do light work around the house or dusting and washing the dishes. More than 4 METs is climb a flight of stairs, walk hill, level, walking ground, or do heavy work in the ground like scrubbing or lifting or movement furnitures. And 10 METs is final. You will participate in any strenuous exercise, swimming, footballing, basketing, and skiing. So in the METs we have this score like the Duke assessment score, DASI score, and it is referred in the ACC 2024 guidelines. The DASI score, the simple questionnaires have the MET scoring, and with the calculation, if the patient achieves a MET of 8 or more, then we can always give a green signal for the surgical intervention. Now coming, where should we do for all the investigation and testing of the patient before a surgery? ECG, preoperative ECG should be obtained in all high risk patients who are going for an intermediate and high risk surgery, and those who are having a high risk also scheduled for a low risk surgery. And preoperative ECG may be considered who have no risk factors, are going for the intermediate risk surgery, and it may be not recommended for no risk factor with low risk surgery. So coming to the echo is not routinely recommended for all patients going for non-cardiac surgery. The current guidelines recommend a patient having symptoms of dyspnea on unknown origin, recent exacerbation of heart failure, as well as a known case of valvular dysfunction with MR. They have to be correlated clinically for post-operative cardiac complication. Non-invasive stress testing, although moderate to large area of inducible ischemia or non-invasive stress testing have to be shown to be a predictor of major cardiovascular event, no indication for stress testing is now routine part of the pre-operative evaluation. Based on the ACC class 2A recommendation, physician can consider this stress testing in patients undergoing a high risk surgery only with a reduced or unknown functional capacity like low METs, and if there is a clinical suspicion that it may change the management during the surgery. Other things which are taken into consideration is preoperative third heart sound or increased JVP, within 6 months of myocardial infarction, premature ventricular complexes coming into the ECG, cardiac rhythm other than sinus, age more than 70, emergency surgeries, significant aortic stenosis, and peritoneal, intrathoracic and aortic surgeries, and markers of poor general medical condition of the patient like renal dysfunction, liver dysfunction, and dyselectrolytemia. So this is the RCRI index that is developed in 1999 as a revision of Goldman's cardiac risk index followed by anesthesiologist. And after this there are various other index, the Gupta NSQIP index and the American College of Surgeon index, the surgical outcome risk index, and the ORB has 2 cardiovascular risk index of 2019, that is the latest. So these risk calculators in general take all the parameters and have a risk score. Nowadays we use the RCRI and the myocardial infarction and the cardiac arrest risk index generally for the routine purpose. So does our patient have a clinical risk factors? So the history of ischemic heart disease, history of decompensated heart failure, any cerebrovascular disease, diabetes and renal insufficiency. These are the red-haired criteria of the going for non-cardiac surgery. So any recommendation of perioperative beta blockers. Now we have to withhold the ACE inhibitors, but beta blockers are very important friends of perioperative status. And for vascular surgery, we have to, there is a class 1 recommendation who are currently on beta blockers. For intermediate surgery also class 1 recommendation, and for low risk surgery also class 1 recommendation. So you have to continue beta blockers, and those patients who are having more than one risk factors also have to take a beta blocker, and that is a class 2A recommendation. Now in 2022 and 2024 the guidelines are have not made a remarkable change. So I will just go through these guidelines. The class 1 recommendation I will just highlight that in all patients scheduled for non-cardiac surgery, an accurate history and examination is a must. And in patients with a newly detected murmur, then only a transthoracic echocardiography should be is a requirement. And in patients scheduled for elective non-cardiac surgery having a chest pain and symptoms suggestive of undetected CAD, further workup is only required. This is the frailty and functional capacity. Transthoracic echo is only required if there is a murmur detected and high risk non-cardiac surgery. And preoperative ECG is recommended for a high risk and for a patient with intermediate and high risk surgery. And these are the antiplatelets recommendation that you have to stop the antiplatelets 5 days for aspirin and 7 days for clopidogrel or prasugrel, and it is recommended that aspirin should be continued 4 weeks after BMS implantation and 3 to 12 months after DES implantation, however how may be the risk of the life-threatening surgical bleed of aspirin may be. So this is the optimal timing of elective and time-sensitive non-cardiac surgery, that if you do a simple balloon angioplasty, you have to delay the non-cardiac surgery with 14 days. If you are applying a BMS, you have to delay by 30 days. If you have the patient have ACS and you have put a DES, then you have to delay at least for 12 months. And if it is a chronic coronary syndrome, you have to delay for at least 6 months. I will skip for the paucity of time. This is one, the transvenous CIEDs, all the pacemakers and the ICDs. If the electromagnetic interference is above the umbilicus, then we have to consider the use of a magnet or asynchronous mode in a monopolar cautery, not in case of bipolar. And in ICD, if the patient is pacemaker dependent, then we have to do a reprogramming in the asynchronous mode. If it is more than 15 centimeters away from the surgical site, then we do not have to do anything. This is the algorithm of a patient who has developed a chest pain after a non-cardiac surgery. Many times we get a reference that if the patient is complaining of chest pain, then we have to first of all order a TROP test and do a history and physical examination, do a 12-lead ECG. If there is ST elevation, then we have to consider a STEMI and patient goes into the STEMI protocol. If there is no clear-cut ST elevation but has at least one criteria of universal definition of MI, and with the symptoms of acute MI and new ischemia, development of pathological Q waves and other things, then we have to go for the further test. And if it is yes, then go for a STEMI. If there is acute plaque rupture suspected, you go for a type 1 STEMI and go for the diagnosis of the NSTMI. If there is no, then you diagnose a type 2 NSTMI and treat as per guideline directed therapy. But if it is not, you have to treat the underlying cause of maybe a non-ischemic cause of the chest pain or a myocardial infarction not related to the ischemia. Last slide, adult congenital heart disease. In patients with ACHD, a consultation of ACHD specialist is a must in patients going for intermediate and high risk surgery, and it is recommended with intermediate high risk elective surgery to perform in a case where center of excellence and experience in case of ACHD patients. Thank you.
Thank you, Dr. Ghosh, for a wonderful speech. So what do you suggest about the aesthetic prior to surgery like beta blocker?
Those who are on beta blockers, we should always continue them. And those who are not on beta blockers, if there are high risk patients, we detect the patients as a high risk patient and going for a high risk and intermediate risk surgery. Then we should add beta blockers according to their clinical status.
No, beta blocker, okay.
Yeah.
But does it, statin has also some role in prevention, post-operative reduction in the cardiac risk?
Yeah, it may have, it has some role.
So statin should be also added.
Yeah, statins should.
Any questions from audience, please?
What about the patient is on ACE inhibitors? What do you advise them? They skip the dose?
If the patient is normotensive on ACE inhibitors, they should skip the morning dose on the day of surgery. Because many a times, many inhalational volatile substances or regional anesthesia may decrease the blood pressure drastically with ACE inhibitors because the vasodilator effect of ACE inhibitors are still there.
Yeah, because we actually in our cardiac surgery practice, we stop it usually a couple of days before because there are a lot of patients become very vasoplesic when coming off bypass. So, and sometime you guys see the patients. I don't know who has to take the accountability. And then you refer the patient to CTVS. Like recently, a couple of patients which was there waiting for cesarean section who has mild to moderate mitral disease. It came for surgical fitness from you guys and referred to the cardiothoracic surgery. So that was a bit weird that what we have to do at that stage, you know.
No, if it is a totally patient is unfit for surgery, planned surgery, cesarean section maybe it may be emergency in the next 1 to 2 days also. But if the patient is unfit for surgery, apart from cesarean section, if we consider that valvular heart disease is totally very high risk, then we have to refer to CTVS for a surgical intervention, or else mitral RHD-MS we can do balloon valvuloplasty to relieve the symptoms and then go for a cesarean section.
No, that was not quite that situation because the patient was pretty much asymptomatic.
So it
was almost near the term.
No, those who are carrying the pregnancy up to the delivery level, don't worry about the cardiac addition and deletion. So stop now here. Discussion, and then I will call the next and last speaker, Dr. Alok Kumar Singh.
I request Dr. B.K. Singh sir to give memento to Dr. Soumik Ghosh. मतलब 9 महीना बिता लिया फिर उसका क्या दिक्कत है?